Do you see my presentation on the screen?
Yes, we can see it.
Okay. Yeah. First of all, thank you for the invitation. It's a great honor for me to be here. Today's my talk is not about glaucoma. It's about strabismus surgery, and I'd like to share my surgical experience to young ophthalmologists, and I'd like to mention that I am not teaching. I am just sharing only my experience. I am Lana Datwashvili from Georgia, Kutaisi. And I'd like to share how I did it. First, I found how I started to do the surgery. First, I found a mentor who was Dr. Tijar de Faber from Holland. He took me in his place in Holland for 3 months and taught me how to do the surgery and everything about the strabismus. Another important thing for young ophthalmologists is to diagnose the squint correctly and then to do the surgical plan. To plan the surgery. How can we diagnose squint? The first thing is important to measure the deviation, to do the cover and cover test, light reflex testing, we call it Hirschberg testing. Also, we can measure the angle by prisms, we call it Krimsky light reflex testing. Visual acuity, fusion, fixation, duction test is very important, also anamnesis, and about surgical history, subjective complaints, family history is very important. On the picture, you can see the Hirschberg testing, how we see the light reflex on the cornea. And if we see the deviation or decentration of the reflex on the cornea, we measure the degrees of the squint. Also, how we treat the squint. The first is to correct the refractive problems with glasses, contact lenses, patching, refractive surgery if needed. Also, I try to remeasure and recheck the strabismus angle twice or 3 times if needed, and if this previous treatment is not enough, we recommend to do the surgery. 3 main surgical tips is first one is to know the anatomy of the extraocular muscles, muscles which move the eye. Also, it's very important to access, the surgeon must be concerned with the mechanical access to the operative site, and we have to remember about scleral thickness while doing the surgery. I think this chart is very important because here we can see the length of the muscles. Mostly rectal muscles are 40 millimeters, inferior rectus also with 40 millimeters. Here you can see the origin of the muscles, anatomic insertion, about tendons, and function of the muscles. Also, besides the angle, besides the length of the muscles, is very important the insertion place of the muscles. We have to remember about these measurements, and I'd like to mention about inferior oblique. It inserts near the macular area, and when we are working on the inferior oblique muscle, it's very important to not tighten it too much because not to damage the macular area. This is a history of strabismus. The practice of strabismus surgery began in 1739. The first surgeon in strabismus field was Taylor, who thought that strabismus was a muscle abnormality that could be treated by dividing the extraocular muscles. On the picture, you can see the Taylor itself. Then there was Gibson, who did the transection of the muscles, and Stromier, who did tenectomies. But the year 1839 is generally considered to be the beginning of the modern strabismus surgery. Indication for strabismus surgery. The most important part for the indication of the strabismus surgery is binocular function, to remain the binocular function, to avoid binocular diplopia, also to remain a binocular field, and especially we think about binocular functions when we do the surgery in infants, and about cosmetic appearance when we do the surgery in adults. This is the different approach. So mostly I use limbal approach, and we have Fornix approach, Swan approach, combination Fornix-Swan. On the picture, you can see the limbal approach. Here I brought some pictures about recession techniques. On the first picture, you can see the limbal starting of the surgery, limbal approach. Then the most important part is to find the whole muscle. Then we suture the muscle. After suturing, we cut the muscle. After that, we do the as we already mentioned, we have to head the plan for the surgery. And after cutting the muscle, we measure the distance from the original insertion to the new insertion place. After that, we're suturing the muscle on the sclera, and then then close the conjunctiva. This is a resection techniques. It's practically the same. A limbal we start with limbal approach. After that,
Не, сейчас пойдем разжигать.
We cut the muscle, and we just suture the muscle in the inserted place. After that, we close the conjunctiva. I have to mention that measurement is very important during the strabismus surgery. So we have to know previously how many millimeters we need to cut or recess the muscle. On the picture, you can see the resection technique during the strabismus surgery. Here, the different techniques how we how we transpose the muscle, cut muscles, or do different techniques during the different types of squint surgeries. Also, I want to mention that it's very important not to overcorrect. We have a lot of different charts where we can find different measurements in monocular or binocular squint surgeries. But the most important thing we can remember that it's just average 1 millimeters is equal to 3 prismal diopters. So it's very important to measure the squint angle properly. And also very important to remember that not to step over the equator of the eyeball. Preoperative warnings might be diplopia after the surgery, loss of vision, under overcorrection, and risk of anesthesia. I mostly use general anesthesia, but it depends on the case. Surgical tips. I always start with FTD test. It's force diction test. Very important to find the whole muscle, correct measurement of the muscle from the limbus. Also, I use suturing for 6-0 Vicryl and also 7-0 for the conjunctiva. I usually do surgery with loupes, but some surgeons prefer to do it under the microscope. So it depends. And about anesthesia, I already mentioned. I think this is a very important part and one of the most difficult parts during the strabismus surgery when you are suturing muscle on the sclera. So you have to feel the thickness of the sclera and not to go too deep and not to leave the muscle too superficial. So this comes with practice, and you have to do many surgeries to feel the depth of the sclera. And also very important not to rupture the eyeball. It's a crucial part, I think. Intraoperative complications: slip to loose muscle, excessive hemorrhage, fat exposure, suturing problems, globe perforation. I'd like to mention that while doing we use cauterizing during the squint surgery, but when when I'm doing, for example, inferior oblique anatomy, it's difficult to visualize all vessels, especially varicose veins around. So sometimes we have hemorrhage during the squint, but it's not so excessive, and we can hemostase compress it. Post-operative care, patching if needed, medications and checkup. It depends, after 10 days, after 2 or 3 days. Post-operative complications, orbital infection, surgically induced necrotizing scleritis, it's very rare, endophthalmitis, anterior segment ischemia, and conjunctival cysts. It's recommended not to take more than three muscles once during one surgery to avoid the anterior segment ischemia. Planning for success prior to strabismus surgery, an important and seemingly obvious question should be asked: why we do the surgery? The goal is to establish binocular fusion, eliminate diplopia, extend the field of binocular vision, correct compensatory head posture, and simply to improve cosmetic appearance. Establishing the goals prior to the surgery helps us to clarify indications for surgery and formulate a logical treatment plan. Now I'd like to share my own case. This was my one of the first patients I started. She was already operated. Her first surgery was 5 years ago. After that, she came in our hospital. It was 3 years ago. It was before my fellowship. And she was operated on her right eye. First, I took already operated muscles, and it was I couldn't find the enough space to do the repositions of the muscles. That's why I got remaining angle after the second surgery. After that, she did laser correction, refractive surgery, I mean, and after 2 months, she came again. Her visual acuity was 0.7, 0.5 in both eyes, and we did again surgery, and I choose in this case I did inferior rectus recession on the right eye to correct the vertical, and also I did I choose to do surgery on non-operated muscles, and I choose left eye in this case, and did recession and resection on the left eye. So we got corrected angle, and she doesn't have any diplopia, and she feels very happy. Thank you for your attention, and Happy New Year.